respected dignitaries on the dais, friends, ladies and gentlemen. It's truly a great honor to be being given this endowment lecture, especially when it comes from people who yourself admire and who have built a tradition of excellence. Nethralaya, known for its competence, what we have heard about them, that is over the years, not just in cataract surgery, whether it is retina, oculoplasty, oculotrauma, every branch, I think they have a series of excellent specialists. And in East India, they have made a name for themselves. And I have known the group for several years, been admirers of them, and truly to be recognized by them is, I can deem it a great honor. I would be talking about challenging situations in cataract surgery. Let me tell you, it's going to be a very simple, straightforward presentation. It's not going to be difficult. These are everyday situations that all of us will face. Maybe I can offer some tips that you can go back and employ it in your day-to-day surgery. And if anything resonates with you, please give your opinions at the end of the lecture. Toric intraocular lenses in PCR as almost 70% of my intraocular lenses today is toric intraocular lenses, whether it's trifocals or EDOFs or monofocal. Unfortunately, none of them come in a three-piece format. As you can see here, this is a situation, everything seemed to be progressing smoothly. But as I inject the lens, the entire lens tilts inward. And just to show you that I did nothing wrong, this was, as I tried to position the lens, this was not an explosive release of the lens. The lens was practically hanging from the tip from on the pupillary margin, and my first impulse was to secure the lens, and I turned it around the wrong way in my hurry. And then, but having secured the lens, one of the haptics outside, I go ahead and deal with the vitreous using triamcinolone acetate. And once it's bereft of the vitreous, I swing the lens around so that it is directed the right way. Now, I do not have support. It's a toric intraocular lens that has been implanted, that's already inside the eye. The fellow has already undergone the surgery. And basically what I do here, there's no support for me at the 3 o'clock, 9 o'clock meridian where the lens is to be implanted. So what I essentially do is to go ahead and place it there, and the haptics are in the sulcus while the optics goes behind. And I go ahead and do an anterior vitrectomy. Once completed, since I had a 5 millimeter rexis, I could create an optic capture. And at the end of towards the end of the surgery, you will see the digital overlay coming on and the lens being exactly positioned. Obviously, it's a little debatable whether you can leave these haptics in the sulcus, but in these situations, sometimes we have to. I put these patients for almost 3 months on tapering dose of steroids, and the occasional cases we have done has done well. This is basically optic capture that was done for stabilizing a toric intraocular lens with a reasonably good visual outcome. Going on to another situation, in this classical posterior polar cataract, in this, in spite of all that I'm going to say subsequently, sometimes you have a pole-to-pole rexis tear like this. But the advantage in this situation is that I have enough posterior capsule at the 3 o'clock and the 9 o'clock meridian. So after doing a adequate anterior vitrectomy, I place the lens in the situation it's to be warranted in the 3 o'clock, 9 o'clock meridian. Again, I have the digital overlay on. But here I want the stability of the lens over the lifetime of the patient. With such a large rent over there, even though on the table I am able to secure it in the capsular bag, I am not too sure about how secure this lens is going to be. So essentially what I do in this situation is to do a reverse optic capture where I go in with a Sinskey hook, bring the optics of the lens forward. So here the situation is that the haptics are in the 3 o'clock, 9 o'clock meridian because there is enough capsular support that is there, but the optics is brought forward. So essentially you can see a very stable lens over there, and this rexis margin here is actually behind the optics of the lens with the haptics in the bag, and this is one other way of securing the lens in a situation like this. And this is reverse optic capture for you. What about a situation that was alluded to in the presentation earlier also, where you have a toric IOL in the bag itself? This was a walk in the park case. I was going ahead with an irrigation aspiration, but unfortunately went ahead and created an PC tear, and right in this area over here, and essentially this will become more prominent as we go ahead. I go ahead and secure this with dispersive viscoelastic. Ideally, I should have done this before withdrawing the irrigation cannula. Then, because it is a secure, well subscribed PCR, I go ahead and implant the entire intraocular lens in the capsular bag, making sure that there is not much dialing involved, but I may just dropping in the haptics into the capsular bag. And fortunately, there was enough amount of support that was available peripheral to the tear, and it's a fairly stable lens that I'm getting in the bag. So 3 situations, 3 ways of dealing with it. This is a large PCR that I have over here, and this is toric IOL in the bag. So though not ideal, sometimes when you get a problem like this, optic capture, reverse optic capture, toric intraocular lens at the back, especially we have made sure that it's not extended, are ways that you can deal with this. I'm sure this might resonate with some of the things that you have done in your own practice. And this is just to show the stability of the lenses over time. What about a refractive surgery in a case of nanophthalmos? This was actually a 20-year-old patient who was wearing plus 17 diopters in one eye and plus 10 diopters in the other eye, was looking for refractive surgery. And essentially, there have been situations, we do prelex or clear lens extraction selectively. And for this patient, as you would see, it was a life-changing surgery. And you can get custom-made lenses made from some of the Indian companies. They make even up to plus 65. The challenge is not to get the lens made. Basically, there's too much of spherical aberration in these thick lenses, thus deteriorating the quality of vision. The more important problem is the variability of the refractive correction. As you can see over here, I've used the latest of formula, including the Barrett, and what you get is a 5 diopter variation in the lens power that is dictated by, in this eye with the plus 10 diopters. In the fellow eye with plus 17 diopters, there's a 10 diopter variation right from 49 to 59. So what exactly is the power of the lens that I will place in this fairly difficult scenario? Basically, whenever I face this situation, I go ahead and do a piggyback lens. As you can see, it's a nanophthalmic eye with an extremely low axial length. And this is just the 40 diopter lens being placed. Gentle parameters, obviously, doing a phacoemulsification in these soft cataracts is not really too much of a challenge. But that's the 40 diopter lens that has gone inside the eye. Both the eyes were done 1 week apart. Then subsequently, we did a refraction. This is what I get. And a plus 6 diopters is what the 6/6 vision with a plus 0.75 in the eye which had a plus 10 diopters. And in the eye which had a plus 17 diopters, I had a residual error of plus 6 diopters. So what I do in these cases is to do a sulcoflex implant. That is, this is the primary lens, hydrophobic acrylic lens, which is there within the bag. And this is a simple calculation for hyperopic correction for a piggyback. For every diopter of hyperopia is 1.5 diopters. If it's myopic refractive error that you are trying to correct, for every diopter is minus 1.5. The sulcoflex lens is a 14 millimeter overall diameter and 6.5 millimeter hydrophilic acrylic lens with undulating haptics, which stabilizes the lens in the sulcus quite well. And basically, this is the lens that goes in. And this takes care of the plus 6 diopters of residual error. And quite surprisingly, as you see in this situation, I just want to show you this. That is, the SRK-T seem to have given the best of results as far as the retrospective evaluation of these results are concerned. I swear by the Barrett formula, but obviously in this extreme case, this would not have worked adequately. So basically, when you have a primary lens in place to debulk most of the refractive error, then placing a secondary lens like this, which comes in a multifocal format in a toric platform also, does help you to get reasonably good results. Basically, for this particular patient, 21-year-old, who was wearing a plus 10 diopter in one eye and a plus 17 diopter in the other eye, it was not a social stigma, but the fact that he could not function quite effectively. It was not vision enhancing, but a life-changing experience for him. Another situation, And as you can see, this surgery which has been done elsewhere more than 12 years back. We thought it's an opacified IOL or a PCO. One of my senior surgeons tried doing a yak capsulotomy. It could not get hold of it, but it was actually pitting the lens. So we went ahead and did ASOCT. We thought it's a opacified lens and we just have to extract the lens. But then when we did an ASOCT, as you can see over here, this is a capsular block syndrome, where you find that the lens itself is pristine, but because of the metaplasia that the cortical fibers and the lens epithelium has undergone, there is fluid accumulation. You might come across this situation in the immediate post-operative period, which can occur sometimes years later also, mimicking a posterior capsular opacification. What you need in this situation either to nick the anterior capsular rhexis margin or create a small nick in the posterior capsule, allowing the fluid to drain out, and then the myopic shift that takes place is also sort of restored. Negative dysphotopsia is another problem. We all know of some of the problems about we face with our premium IOL patients, but negative dysphotopsia is a problem that sometimes makes patients quite unhappy. Essentially, these patients complain of a temporal crescentric shadow. It's called the salute sign, where if they place their hand over here, the dysphotopsia completely disappears. It happens, unfortunately, post-anatomically perfect surgery, where you have got a good rhexis overhanging the optics of the lens. It is more commonly described with a hydrophobic intraocular lens with a sharp edge design. And that's the reason that it's become more and more obvious in the 1990s and the 2000s, when such intraocular lenses becoming more popular. So essentially, when you are faced with this situation, and mind you, I have had situations where it has been extremely disturbing to the patients, or it has been such cases have been referred to me. First is you do nothing, because 97% of these patients, it can occur as frequently as 17% of your patients in the immediate post-operative period. By 97% of them, it resolves on its own with neural adaptation. So counsel patients for yourself as well as the patient, and most often, unfortunately, the problem goes away. The problem is said to be, Sam Maskett has done the seminal work on this, is because the nasal edge of the anterior capsular rhexis, which is on the square edge of the optics of the lens, which is implicated for this. And disrupting this nasal edge or hiding it is supposed to be the basic way that you treat this problem. One of the simple ways that you can treat this is to do a yak capsulotomy to the nasal edge of the capsular rhexis. As far as you're doing it to 3 to 4 clock hours, as you can see this, one of my cases where I've done this and the nasal capsular rhexis margin is disrupted. Not the entire capsule, but even 3 to 4, the continuity is disrupted, the problem gets relieved. But this is not always easy to do, because some of these pupils do not dilate well enough to show you the nasal rhexis margin. And sometimes once you nick this, the capsule becomes a little floppy and there's no tautness, and you cannot go ahead and complete the rhexis. But if it is visible, most often you can do this. We have done about half a dozen cases like this, and most of them, the problem subsides quite significantly over time. This is another scenario. This is a radial keratotomy I had done more than 35 years back, sometime in 1991 or something like that. This lady came to me, had some residual error, but then the cataract surgery itself went off. I put a hydrophobic acrylic lens. Surprisingly and thankfully, a very good, satisfactory refractive outcome. But she was extremely bothered by the negative dysphotopsia which persisted for her. Spent almost 6 months. It was a hydrophobic acrylic lens. The patient was a very devoted patient of mine, but was extremely disturbed. So as you can see here, there's the edge of the capsular rhexis is not visible, so I cannot handle this. So what I'm doing in this case is to do a reverse optic capture. Obviously, this is a hydrophobic acrylic lens, and as you can see, the lens itself, the capsule is going to be quite adherent. So using a cohesive viscoelastic, having injected into the capsular bag, I first gently tease off the capsular rhexis margin from the optics of the lens, and then it's doable, though it's challenging. Then go behind with an iris spatula, lift up the entire optics of the lens out of the capsular bag, and then gently insinuate the optics of the lens behind the pupil. That's essentially what I have done, is to hide the rexus margin itself by the optics of the lens, so that the overlap of the rexus margin of the optics is not there. We have just done 2 eyes with this particular procedure, anecdotally reported also, but in both these patients, it seemed to work in these patients. Severe negative dysphotopsia, in this situation, it was a lawyer patient who was referred to me by a friend of mine from a neighboring town. Excellent surgery done, emmetropia of a distance, you can see the toric markings, and an extremely demanding patient and very disturbed by the negative dysphotopsia. He did not want to compromise on the refractive outcome also. So the question of disrupting the rexus or bringing out the lens out of the capsular bag was out of question. So what I did in this situation is what I showed you earlier, use a piggyback lens of 0 diopter power. So essentially the logic behind this particular lens in this situation is to hide the square edge optics of the lens with a 6.5 millimeter optics, which is 14 millimeter undulating haptics. There is no refractive outcome, but once the edge of the lens was hidden, this patient especially was extremely happy, and negative dysphotopsia disappeared. He insisted on getting the second eye done by me. I said he could face the same problem. I put the same hydrophobic acrylic lens, did similar surgery, but no negative dysphotopsia in the second eye. Not because I did the surgery, but because there's so much more that we don't understand about this phenomenon. And oftentimes this negative dysphotopsia can be a unilateral situation. One very innovative technique from Roop from Meerut, he has come up with this negative dysphotopsia ring, where essentially what you need is not the optics, but a simple ring where there's a central hole over there. It's a 6.5 millimeter ring. It has 4 loops that are there, and you essentially fold it like a taco. And this was another situation. I've just used 2 of these rings so far, and you can inject it into the eye. It doesn't look like a very controlled surgery, but the surgery itself works well. It's a fairly cheap solution in case the patient cannot afford a piggyback lens. And you can see this being positioned in front of the optics of the lens, and subsequently, because of the hiding of the rexus margin, the problem tends to subside. In these two, out of the 2 cases that I did, one case did very well. In the other case, the patient did not have a significant improvement. So obviously, it's a problem that we do not understand completely. This is something which is close to my heart, and there's something that we have started doing routinely. This is a Swepso's ASOCT-based management of the posterior polar cataract. This is the routine surgery that we all do when we are faced with a posterior polar cataract, where we do not do any hydrodissection, we do not rotate the nucleus. What we do is a gentle mechanical delamination, no hydrodissection, no nucleus rotation, avoid AC fluctuation, make a small rexus, and always tell your patients guarded prognosis. But because we have not done a hydrodissection and not rotated the nucleus, the surgery itself seems to be less controlled, more cumbersome. Sometimes that itself leads on to a PCE tear. So is this dictum really to be followed? So essentially, there is better understanding that is evolving as far as posterior polar cataract is concerned. Though on the slit lamp, most of them appear similar, when you put them under a Swepso's ASOCT, essentially this kind of a classification is now accepted and well established, where you have an intact posterior capsule, which is group 1. In the prospective study of 76 eyes that we did, 75% of the patients belong to this group, where you have an intact posterior capsule, albeit it might be thin. There's again, you have there's another 24% belong to this group, where it's group 2, where you cannot delineate the posterior capsule behind the posterior capsular plaque. And then there is a third group, where there's a dehiscent PC with obvious lens material in the petaloid fossa. And essentially, once you have the intact PC, our theory is that these are situations like this. 56 of these eyes in which we conducted a prospective study, we went ahead and did routine phacoemulsification. There are 5 experienced surgeons who did this. And as you can see over here, you would find that I make a capsular rexus of 5 millimeter, and subsequently watch out for that hydrodissection, which is considered a strict no-no. Basically, we just go ahead and the Howard find the way he described, lifted the rhexis margin, and you can see the fluid going right across the nucleus. What suggested not to be done in these cases because of the confidence that I get with my ASOCT, gentle rotation of the nucleus, and you see that there are gentle parameters that we are using. Even though the posterior capsule is dehiscent, is continuous, we are cognizant of the fact that it might be quite thin. So as you can see, I do the routine chopping, removal of the nucleus. So essentially, whenever we are faced with a situation where the posterior polar cataract is there, the PC appears intact, we go ahead and handle it like a routine phacoemulsification. And out of the 56 size, just one eye had a PCR, and when we retrospectively reviewed these eyes, we found that even in that case it could have been avoided if only the surgeon had been a little more careful with a particular step. When it comes to group 2, where you can see there's a PC discontinuity, where we cannot have a continuous posterior capsule behind the posterior plaque, essentially what we do is what is described in the textbook, the dictums that we follow always: create a 5 millimeter rhexis. This is a grade 2 to 3, a little firm cataract, no hydrodissection, but only hydrodelineation, and then subsequently no rotation of the nucleus. What I do is to debulk the epinucleus, create a small trench, and the inferior heminucleus is essentially split up into 3 segments without any rotation of the nucleus. And then each of these segments is subsequently extracted and removed, and thus removing the pressure on the capsular bag, and then subsequently bringing the superior heminucleus into the 6 o'clock position after doing a little bit of viscodissection, and then we address the inferior heminucleus. Even in these situations where the posterior capsule appeared to be discontinuous, it was only in 25% of the cases, that is in 1 in 4 cases, that we had a PC rent, and that's the good news. That is, even though the PC may appear discontinuous, then it's not that in every case you would end up with a PC rent. This was only one case where we had obvious lens material in the posterior, in the petaloid fossa. In this situation, obviously, we did not do a hydrodissection, but it was just a hydrodelamination that was done. And then we went ahead and that's, you can see a small confined hole and some lens material in the vitreous cavity. But the PC itself held on, and we could place a multifocal lens in the bag. So essentially, we have published this now, and this is almost more than a year since we have published it. And subsequently, we have been following this, and it seems to work well in our hands. So I do submit that a good Strepsos ASOCT determination of posterior capsular integrity is a good idea. And just in case you find it to be continuous, then you can go ahead and deal with it in a normal manner. Do I have a little more time, or sure? Okay, just maybe whenever you feel. I have a couple of more situations. This is just what we alluded to earlier, that is the dead back syndrome, late dislocation of multifocal intraocular lens. This was a multifocal PMMA intraocular lens I had placed about 25 years back. This was a Pharmacia Hall PMMA intraocular lens that was placed. And as you can see, the patient had excellent vision for almost 25 years. I had done the surgery in 1999. And a couple of years back, he presented to me with this situation. One eye, he was still doing well. The other eye, you can see an extremely clear back, but the lens had got disrupted. So obviously, we all know about this dead back syndrome. This was a classical situation. There's hardly any fibrosis of the back. So what I do in this case, it's a planar lens. And what I do in this case is to go behind the lens, essentially maneuver the lens out of the capsular bag in front of the rhexis margin. I was a little doubtful as to whether this rhexis margin would be good enough to create a adequate optic capture. I decided to just take a chance and do that because the patient was still quite happy with the multifocality in the other eye, insisted on trying this out. Otherwise, if this did not work out, the idea was to go ahead and do a scleral fixated intraocular lens. As you can see, I brought the lens out, and then in the capsular rhexis margin, which has been created more than 25 years back, I am gently sliding the the haptics in front of the rhexis margin, then creating an optic capture. And ideally, I should have done a vitrectomy a little earlier. I'm using triamcinolone acetate, and you can see a large wick of vitreous which is coming right through. I go behind the lens also, evacuate the vitreous quite completely, and you can see a good optic capture that had been created with a stable lens. I have a follow-up of couple of years on this patient, and this lens has held on. Another situation, as you can see, this is just to show you a post-operative picture, what I encountered pre-operatively a couple of years back, and this is a recent picture with some amount of opacification in the periphery, but the lens being well-centered and quite stable. Dislocated plate haptic intraocular lens. This is a situation again of a dead back syndrome, where you can see a plate haptic diffractive lens which has got dislocated. And obviously in this situation, I wanted a vitreoretinal colleague of mine to help out, because I expected this lens to go south. And exactly as he went ahead with the 3-port vitrectomy and started doing this, the lens dislocated. Thankfully, I was not handling the case, and my vitreoretinal colleague went ahead and used the equipment that they normally do, freed up the vitreous, and then brought the lens forward through the large PC ren that was there. In this case, again, the capsular rhexis margin was quite stable, and he shifted the lens into the anterior chamber. But so this when you are senior enough, you get cases presented to you like this with the difficult parts already being done. So in this situation, what I had to do essentially was, the idea was not to leave behind this plate haptic lens in the sulcus, but just a 2.4 millimeter incision that was created. And there's no need to cut these hydrophilic intraocular lenses. Basically, once you use a hand-over-hand maneuver, the lens folds on itself and the entire lens is coming out, as you can see, in a single piece. There's no cutting that was involved. The patient again was quite clear that he wanted multifocality, because he had that in the other eye and it had served him quite well. So having told him that it might, this is not the right place for putting in a lens, is essentially a continuous range of vision intraocular lens that I'm putting in the eye and in the sulcus. Basically, it's not a place for a hydrophobic acrylic lens, and it's not that I would routinely recommend. But again, as you can see, I'm doing this and then subsequently creating an optic capture to stabilize the lens, and then it again holds on. And as you can see, this is what the situation we encountered initially and what we ended up with. And I think I'll make this the last of my scenarios. I will exchange for an unhappy presbyopia correcting intraocular lens patient. As we all know, there are several varieties of multifocal intraocular lenses that are available today. This was a lens which was based upon a spherical aberration principle, using a positive and negative spherical aberration. And essentially what this patient had come from Uganda, Indian settled there, underwent bilateral surgery by a colleague of mine, and then very unhappy with the visual outcome, not only the quality but also the quantity of vision. Had a mixed astigmatism and required additional glasses, not happy with the quality of vision also. Went back, waited for about 3 months, and when he did not do any better, and he was just 42 years old, wanted the multifocality to be preserved. So what we did, this is how the cases presented me. Did a detailed investigation. Essentially, his cornea was quite pristine with a high rod aberration of less than 200.2, and his angle alpha was also less than 0.5 millimeters. So essentially decided to go ahead and exchange these lenses. And as you can see over here, I'm going to do lens scaffolding over here. 3 months, it's a hydrophilic acrylic lens. This has a peculiar 4-loop haptics. It's a fairly large lens, and then I'm just bring the lens out of the capsular bag. And in this case, I had to bisect the lens quite completely. So the plan was to inject a continuous range vision intraocular lens into the bag. And when you have this lens in the bag, then your POIC is automatically protected. So I essentially dial this lens into the bag. Then subsequently I go ahead, and because this is a fairly large lens that needs to be extracted, what I do, holding the optics of the lens, I bisect the lens into 2 complete halves. The intraocular lens being already there acts as an IOL scaffold, protecting the posterior capsule, and with a hand-over-hand maneuver, I remove the 2 segments of the lens that was already bisected. So essentially, just because one aspect of multifocality did not work, That does not necessarily mean the more accepted diffractive design will not work in this patient. Of course, problems at dysphotopsia and whatever you counsel is always there, and you talk to the patient. A week later, the patient underwent lens exchange in the other eye and ended up with a fairly happy outcome. Shall I stop here? Thank you so much for your kind attention. I think I still have a few scenarios, but I've exceeded my time. Thank you very much.